Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you for joining us today and our friends at the Community Health Center of Cape Cod for hosting today's session, Hepatitis C, Evaluation and Treatment with Dr. Philip Styne. Dr. Styne, if you give me 1 second, I will pull up your slide deck and then we can begin. Over to you, Dr. Styne.
Good morning. Good morning. Hi, my name is Phil Styne, and I'm a gastroenterologist. This is my disclosures. I don't have any disclosures. And again, as Kristen mentioned, this is accredited for a Category 1 CME. Our objectives this morning are to understand the indications for hepatitis screening in both general and special populations, to know the effect of changing demographics on hepatitis C, to understand pertinent positives and negatives in the history and physical exam, and to interpret the lab for hepatitis C patients and make decisions about therapy. Next slide. Interpret those findings, incorporate them into treatment recommendations, understand post-treatment follow-up, and understand when to refer for specialty care. Next slide. So I will admit this is an old slide, and actually some of the colors somehow got distorted, but as you can see, the United States is sort of in the mid of the population frequency for hepatitis C. Next slide. This is a timeline. There won't be a test, I promise. But if you look far to the left, what you'll see is that in 1984, we still called this non-A, non-B hepatitis. And far to the right, from 2017, we're really on the idea that we can eliminate this disease in our population. I think that's the most important thing to gather from this slide. The next slide. Please don't try to memorize this, but do understand, and I point this out every time I talk about this sort of thing. There's an incredible amount of basic science which goes into our ability to treat this virus, as an example. Understanding of the protein, and in this case, the RNA that is the crux of this protein, and how it produces the proteins and how those allow this virus to function, and therefore how to use medications to block them. Basic science, it's a big deal. Next slide. The importance of this slide is really that, unfortunately, there was a baby boomer spike in hepatitis C, but we and you all are living a spike due to the drug use in our younger population that has now produced a second spike in hepatitis C. The second spike is also important when it comes to seeing a patient with hepatitis C, because if they're in their 60s, they are much more likely to have advanced disease than if they're in their 20s or 30s. Next slide, please. This sort of bears this out. Acute cases in 2011, 17,000. Acute cases in 2022, almost 68,000. That is this spike that we're seeing. Next slide. The other point, and really the reason that I try to encourage people to, at primary care level, consider treating hepatitis C is, can we go back one slide, Kristen, is every time a patient moves through the process and has to go through another step, and especially if they're diagnosed at a primary care level but have to be sent to a specialist, we lose patients. And by losing those patients, we lose opportunity to rid the patient of their hepatitis C and also reduce the burden of hepatitis C in the community. So the reason that I want to give this talk is because I want to encourage primary care providers to treat uncomplicated hepatitis C. Next slide, please. So this again is this idea that there are stages of this disease, their importance of knowing about comorbidities. There are, in some cases, in some states, resistance to treat patients who have active drug or alcohol problems. And insurance status obviously has some restriction on hepatitis C therapy. There are also the idea that there are populations who clearly are at higher risk. And this list on the right should be of no surprise to anybody. Next slide. This slide, a little complicated, but the idea really is that treating patients with hepatitis C reduces morbidity and mortality. And even in patients with advanced disease, cirrhosis, who we can obtain sustained viral response, which is our term for cure, because we don't know really what's happening with this virus. We see that it's gone by evidence, but we call it sustained viral response, and you'll see that term SVR a lot of places. We can dramatically affect morbidity and mortality by treating these patients, even at an advanced disease. Next slide, please. So this is a cascade. Point of care testing. Reflex testing refers to the idea that if a patient has a positive hepatitis C antibody, that the lab automatically does an RNA, which tells us whether or not they have active disease. Because if the patient has a positive antibody, but a negative RNA, it means they either self-resolved or some previous treatment resolved them. Adding that extra step, okay, Ms. Smith, Mr. Jones, you had a positive hepatitis C antibody test. Now we have to send you back to the lab for another test. And as you can imagine, every time we do that, that's where we lose patients. The next bar across is that because we have medications that will treat all genotypes, especially for patients without advanced disease, genotype testing prior to treatment is not necessary. The next line, simpler tools to try to, I'm sorry, not next slide, next line, simple tools to triage those with and without cirrhosis, using something called FIB4, which is a calculation that you can do, and if necessary, elastography, which is essentially a fancy ultrasound to try to decide if people have significant fibrosis. And then the last line on this slide, the idea that simple pills for 8 to 12 weeks and doesn't require ribavirin, which has a lot of drug-to-drug interaction, and really virtually no during treatment monitoring, and reducing the cost are the ways that we, primary care providers and hepatologists, can advance the treatment of this disease. Next slide, please. Okay, why should primary care treatment? Again, we talked about this. Early treatment was complex. It's so much simpler now. Extra step loses patients. Pre-treatment assessments can be easily well defined. Treatment today is straightforward, and follow-up requirements are limited. So again, this is this sell to you all, to primary care providers, that treating hepatitis C is well within your purview. Next slide. Acute disease is awfully undetected. Very rarely do you see patients with acute hepatitis C. It's uncommon. I can count on fingers and toes the numbers that I've seen. 80% become chronic, which means that 20% isn't. So there are people who get hepatitis C, who have a positive antibody, who never had treatment, who are RNA negative. But again, it's 80%, so much, much higher actually than adults transmitted hepatitis B. It takes decades in most cases to develop cirrhosis unless there are accelerators. And the accelerators are important for you all to know, because in maybe a 30 or 40-year-old who has had disease for 10 years, they might have cirrhosis, even though usually cirrhosis takes 30, 40 years. Alcohol is sort of an obvious one. Mafdil, what we used to call NASTL, okay, or non-alcoholic fatty liver disease, is now, and actually this is a typo, it should be metabolic associated steatotic liver disease, and HIV are accelerators in hepatitis C. Next slide, please. Transmission bloodborne, but again, there's lots of ways of getting bloodborne. Sexual transmission is relatively low unless the acute phase. The acute phase sexual transmission is a little higher in this young spike that we have, but it's still not very high. Vertical transmission from mom to baby is been sort of considered not to be a big deal, but I think we're recognizing it a little bit more. And it is an issue because in general, we don't treat pregnant moms with hepatitis C therapy during their pregnancy. And different than hepatitis B, once baby is delivered, we don't have a way of baby avoiding getting hepatitis C. So vertical transmission is still a bit of a sticky wicket for us. Next slide. So screening recommendations. Some of y'all may remember that a while back at the CDC and U.S. Preventative Task Force recommended screening for we'll call baby boomers, but now we're pretty much recommending that everyone, and they say between 18 and 79. I think that kids probably starting at that 15, 16-year-old range, if you have an opportunity, and certainly if they're pregnant in those under 18 years, need to be screened. Yearly screening for high-risk patients and special clinical scenarios. One of my biggest annoyance is that a patient comes to the emergency room with an IV drug overdose and doesn't get tested for hepatitis B or C, or HIV for that matter. And I have a personal vendetta against that issue. And I'm working with emergency rooms through a Florida state agency. Next slide, please. Special populations: IV drug users, obvious, pregnancy, dialysis patients, prisoners, drug overdose again, and men who have sex with men. Next slide, please. Okay, so evaluation of a patient with a positive hepatitis C antibody. Maybe they come to you, maybe from a health department, or maybe you've tested them and they're positive. Genotype, we used to do regularly on everybody because the therapies were genotype specific. Now that's no longer the case. I tend to order a genotype and if there's no financial impact, but it really is not as necessary as it was. You want to establish a degree of liver damage, history of likely duration. When was their likely exposure? I'm seeing a 50-year-old who tells me that when they were in college, they shot up drugs a few times, or whatever few is. Then I think they probably have disease for 30 years. Or if they're a 20-year-old, they probably don't have disease for 20 years. So a history of likely exposure. Obviously, any history of decompensation to suggest cirrhosis, a liver-directed physical exam, spiroangioma, hepatomegaly, splenomegaly, ascites. A FIB4 score is a calculation that you can do based on basic lab, including AST, ALT, and platelet count. There's a number of 1.3. If they're below that, it's extremely unlikely that they have advanced disease. There's a number 3.6, which if they're above it, it's quite likely that they have. That obviously leaves a pretty big gap in the middle. And if you can look at those patients more carefully, again, think about the history. FiberSure is a blood test, fairly expensive. Ultrasound and CT can suggest advanced disease, splenomegaly, liver nodularity. And a fiber scan is the thing we refer to elastography, which is available in most hepatologist offices, some gastroenterologists, and probably fairly soon, even an endocrinologist office, where we can determine non-invasively, meaning with a liver biopsy, fibrosis. But mostly what we're looking for in these patients is, are they cirrhotic or not? Next slide, please. So length of disease can often be estimated. We need to be sure that they're not co-infected, because co-infection with B and C makes treatment of C complicated. Obviously, if they're co-infected with HIV, we talked about fatty liver, alcohol, and I hate to say it, as complicated as it can be, as William Osler said, a man can have as many diseases as he damn well pleases. So you will see patients with hemochromatosis and hepatitis C. And I've been fooled. Alpha-1 antitrypsin, also not as common, but something that we often need to think about, especially if the patient has some history of pulmonary disease in addition to the hepatitis C that you're seeing them for. Next slide, please. Physical exam. These are all fairly obvious, and these are all going to be advanced disease. Next slide. So in addition to getting a hepatitis C antibody and then the RNA, okay, that we want to get to confirm that they have active disease, we're going to want a CBC with platelets, because we're going to want to make sure that they don't have a low platelet count suggesting cirrhosis. A full CMP, which will give you a creatinine. On a proton INR, again, to give you a hint of whether or not they have advanced disease. B markers, surface antigen, and core antibody IgG. Again, we talked about scans if we think that they're advanced disease. Pregnancy test if appropriate. The next line is not mandatory for treatment, but mandatory for care. Any patient that you see that has hepatitis C, you determine they don't have active B, you want to know if they're immune to B and if they're immune to A, because every patient that you see, no matter what their liver disease is, including fatty liver, should be immunized for B and A. And I have considered genotype, but not necessary to treat. Next slide. Referral to hepatology, cirrhosis, co-infection with B or HIV. The reason the HIV drugs become very complicated, and I don't go there. I use my ID compatriots. Active hepatitis B complicates hepatitis C treatment. In fact, actually, even chronic hepatitis B, which is not particularly active, can be actually activated by hepatitis C treatment. So knowing a patient's hepatitis B status is important. Previous failure with direct-acting antivirals that does not interfere on ribavirin. So if the patient had a previous failure to interferon on ribavirin, they do not need to come to see me. You can treat them. Concerns about additional hepatic disease and complex medications to avoid drug-drug interaction. Most of the drug-drug interactions occur in patients on psychiatric drugs and a few cardiac drugs and St. John's wort, which I'm always a bugger. Next slide, please. Okay, standard treatment. Don't try to write this down. Just get this, that there's 2 drugs out there, that one's 12 weeks for standard patients, one 8 weeks for standard patients. Both of them are 1 dose a day, though one of the doses is 3 tabs taken at the same time. But these are easy medications. They're from AbbVie and Gilead, and both drug companies have programs for patients with no insurance and no funds. I have 2 clinics, and I get free medications for virtually all of those patients. There's a little bit of paperwork, but it's actually, paperwork's become a lot simpler. So simple medications, short duration, and very, very high cure rate, 95+%. Next slide, please. Mentioned drug interactions. You all are going to get the slide deck, so don't try to copy down this drug interaction checker. And to be honest with you, I have a PharmD on speed dial because every once in a while I'll get some patient who's on 10 psych drugs and I don't know where to go. So it can complicate even my treatment. Next slide. Treatment monitoring. It used to be said that you should get a CMP and a CDC a month into treatment. A lot of times I don't get it because I think this person who's homeless is unlikely to get it. You do want to get at 12 weeks after they finish therapy, a CMP to make sure their transaminases are normal and an RNA to make sure it's negative. That is the main significant follow-up. Next slide, please. Okay, so here's a case. 57-year-old comes to you, they're told that they have a hepatitis C antibody that's positive. They used IV drugs 30 years ago. Their hepatitis C antibody is positive. Their CBC is normal. They have mildly elevated transaminases and uninterestingly a glucose of 123. Their hepatitis C RNA is negative. They don't have active disease. Their surface antigen is negative, but their core antibody and surface antibody is positive. So they also got exposed to hepatitis B and got over it. So they got exposed to C, got exposed to B, and got over it. Next slide. But you check a ferritin, it's 1235, and they probably have hemochromatosis, which is why they have abnormal LFTs and type 2 diabetes. Hemochromatosis is a relatively common disease. And so think about getting a ferritin in patients who you're unsure what's going on with their liver disease. Next slide. Case 2. So here's a 21-year-old came to the ER with an opioid overdose, referred for hepatitis C. Hepatitis C antibodies positive and HIV is negative. Surface antigen is negative. CVC is normal. CMP, mildly elevated AST and ALT. RNA, 5 million, very common to see it in the millions. Next slide. Again, we're going to check their B markers. They are immune to hepatitis A. We did a pregnancy test. Okay, so diagnosis, active C, immune to A, but not immune to B. Next slide. So what are we going to do? We're going to treat their C. We're going to vaccinate them for B. And 12 weeks after finishing treatment, we're going to check a CMP and RNA. We're also going to counsel them. Having hepatitis C does not provide future immunity. So as I tell them, anytime you do something stupid, you can get this disease again. It's a very important point. Next slide. Another patient, male, hepatitis C for many years, treated with 3 months of shots and pills, but stopped because not working. Back then, a liver biopsy showed scarring. Admits to IV drug use 40 years ago. Hepatitis C antibody positive. CBC shows a low platelet count. Transaminase is mild. Bilirubin slightly elevated. Next slide. RNA, 3 million, not uncommon. All B markers negative. Why did I get an alpha-fetoprotein? I got an alpha-fetoprotein because I'm concerned that they've had disease long enough and they're cirrhotic and they could be at risk for getting hepatocellular carcinoma. So I'm going to do an ultrasound. And in fact, actually, they don't have any focal defects on ultrasound, but they do have a big spleen confirming they probably have cirrhosis. And here's their FIB4, 3.5. Pretty clear that they likely are cirrhotic. Next slide. So our assessment, they have active C, cirrhosis. I would at least call a hepatologist, talk to them about it. We at MAVEN Project have referrals that you can do. So you can talk to myself or one of my colleagues. You're going to vaccinate them for B. In advanced disease, genotype may be useful in treatment if they're decompensated for sure. Treatment and refer. Why do they need to be referred? Well, they need to be scoped because we need to know if they have varices. And they are going to need, even though you cure their hepatitis C, this is important, they're going to need hepatocellular carcinoma screening every 6 months indefinitely. Because even though they're cured of their hepatitis C, they are still at risk for getting HCC. Next slide. For sure, they can understand they can get it again. Vaccinate for A and B. If any suggestion of advanced fibrosis, they need long-term monitoring. And I have this little recruitment discussion. I say to this 20-year-old, you know, it's not likely that I have friends who have hepatitis C who've done some IV drugs, but you do, and I've cured you of your hepatitis C. Tell your friends that they should get checked. And I get this recruitment discussion at that 12-week post-therapy when I get their lab, and I get a ton of referrals by doing that, because really we're trying to treat individuals, but we're also trying to treat the community. We're trying to lower the hepatitis C burden in our communities. Next slide. So there's a couple of websites, hcvguidelines.org, this FIB4 calculation from the University of Washington, a drug-drug interaction. And if any of you have access to UpToDate, it has excellent article on treating hepatitis C. I refer providers to UpToDate all the time. I don't get anything back from it. Anyway, next slide. And again, this is, the idea that, MAVEN Project has the opportunity for you to have consultations about individual patients. And you can certainly reach out to us on any patient. I have a lot of primary care providers in the Orlando area treating hepatitis C that I have mentored. They have me on speed dial. They contact me all the time about patients with some potential problem. They did routine lab and the ferritin is 800, or some other aspect that they're not sure what to do with. And I think that because I'm encouraging primary care physicians to treat these patients, to go a little bit beyond what they're used to, my job is to provide them with the support to make them feel comfortable doing that. And that's part of my preachiness of this talk. Next slide. This is me. This is my email. Reach out to me.
All right. Thank you so much, Dr. Styne. That was great. Just a reminder, if you are using this computer, if you are signed into the computer, you will be considered attended. If you're watching with a friend, so your name does not show up anywhere on the participant list, chat list, please put your name you can email me or put the name of the person viewing on your computer into the chat to make sure that they get the slide deck and credit. Okay. First question. Oh, and please remember that you can put your questions in the Q&A box, chat box, use the raise hand feature, speak out loud. First question. Does prior treatment alter selection of retreatment?
Yes, absolutely. And I only mentioned 2 of the drugs that are available for treating hepatitis C. There are even more advanced ones, but those I think should really be either done by a hepatologist or done in concert with a hepatologist, because if the patients have had previous Epclusa or Mavorix, any direct-acting antiviral, the selection of the next line of direct-acting antiviral gets complicated, and we don't want to miss out the second time. So yes, but if it's interferon or interferon and ribavirin, that doesn't count. You can use standard drug, Epclusa or Mavorix.
Great. There's a comment in the chat about just like I will likely start a program in the next few months. If you ever need assistance with that, remember that you can use Dr. Styne for a consult or even mentoring. All right. Next question. Sometimes when doing the iron panel, the ferritin is normal, but the transferrin saturation is above normal. Should the patients be screened for hemochromatosis?
Hemochromatosis. Yeah. So first of all, let me mention that ferritin is an acute phase reactant, so it's not uncommon for the ferritin to be in that 500-600 range, which is above normal, but not likely to have hemochromatosis. I have probably a too low threshold for testing for hemochromatosis. So I'm sort of paranoid that I'm going to miss it. There's a relatively simple genotype test, though not inexpensive, looking to see if they're homozygote for C282Y or H63D, which are the genotypes associated with hemochromatosis. I think if you have a patient with either an abnormal saturation or an abnormal ferritin, probably the best thing to do is to do the hemochromatosis genotype screening. And then if that's positive, then you're down to either doing a fancy MR or maybe considering a liver biopsy. If not, another thing that you can do is to phlebotomize the patient and see what happens to their hemoglobin. If they have hemochromatosis, their hemoglobin will stay up, and if they don't, but I think that's something that probably, and I would say, is in the hepatologist's purview. I don't know if that answered that person's question. If they want to ask follow-up questions, have at
it. Are we close at all to cheaper Hep C RNA equivalent, or the CAG?
Okay, so just released by the FDA is a point of care hepatitis C RNA, but it requires a specific kind of a machine to use. Now I sort of lost the question. I'm sorry, Kristen. Read the question again to me. I apologize.
Are we close at all to a cheaper Hep C RNA equivalent / the CAG?
No.
No. One day. Okay, let me just go back into the chat real quick.
There was something about screening for hepatitis C not being paid by Medicare.
Yeah. Common problem we see, Medicare doesn't pay for Hep C screen and test is greater than $500. How do you get around this?
Yeah, okay, so unfortunately, I cheat, okay? I'm practicing currently in a clinic where patients have no money, no insurance, nobody has anything, and I get all my lab free from the two local hospital systems, okay? So I bypass this problem. This is an absolute problem, okay, all right? And somebody directed me towards a coding for viral screening that they said Medicare would pay for. And I have not pursued it, again, because it's not in my practice realm. But it's a very good question. And I am going to research it. And Kristen is going to make sure that I have that questioner's contact information so I can work backwards towards that.
Love that. I will write that down. Next question. When we do the next question. Okay, let me just see. Is there a gold standard lab test for hemochromatosis? Why can't I say that word this morning? For hemochromatosis. Yes. Is there a gold standard lab test?
Okay, so the basic screening would be a ferritin. Okay, if the ferritin is not elevated, then it's unlikely they have hemochromatosis. If there's a high suspicion for hemochromatosis, then doing the hemochromatosis genotype, okay, yeah, and this Jonathan Gates has just put up this ICD-10 code. That's the one that they're talking about. It's screening for viral disease. It doesn't say specifically for hepatitis C. It's screening for quote unquote viral disease, and that's the one that people have been talking about. And I think that Jonathan is correct. Back to the hemochromatosis thing. So the thing that I do probably maybe more often than I need to is to order this hemochromatosis genotype screening, which is looking for the C282Y and the H63D translocations.
Given that 50% of patients don't know they are affected, what are the estimates of Hep C prevalence?
What is the estimates? It's in that one of those very first slides. In the United States, it's probably in the neighborhood of about 1%. Now, realizing in special populations, for example, in prisoners, okay, it's in the upper teens. It's like 15, 18%. Okay. There's a drug rehab program in Orlando where we're getting screening for everybody who gets admitted to the program, and it's pushing 30%. 30% of these kids who are admitted into this IV drug rehab program, if they were taking pills, they don't get screened. If they're using IV, they get screened. So 30% of the IV drug abusers are positive for hepatitis C.
Right. If we're in a situation without any backup, i.e., overseas, how bad is treating a patient with decompensating cirrhosis with drugs? If no option, should we treat?
Okay, my answer would be contact me um because we can do it. Okay. Um, there's some nuances to it. Okay. I would ask for a genotype because it does matter in decompensated disease. um, but I see patients in my pay liver transplant clinic who are referred to me for a liver transplant because they've had decompensation. I cure their hepatitis C, and within months, they're off the transplant list. We are avoiding transplanting patients by treating advanced cirrhosis. So the answer to the question is it can be done. It's a little dicey, a little more complicated. Contact me.
How often to request EGD in cirrhotic patients whose first scope doesn't show active varices, especially if treated?
Okay, so it depends on how convinced I am that they have portal hypertension. For example, if on ultrasound or CT their spleen is not big, but they have a knobby liver, so they probably have early cirrhosis, but they don't have big time portal hypertension. Their spleen's not big. On the other hand, if they have a big spleen, um, or they've had ascites, okay, then we scope them every 6 months. Um, but I think it's sort of individualized that depending on how high your suspicion is for portal hypertension.
Several drug companies with Hep C drugs still require genotype, even though the drug is pan-genotypic. Can you
No,
help us? Nope.
for both Gilead and AbbVie, and again, I don't have any connection to any of these companies. Um, they have been just outstanding in terms of treating. We have treated literally hundreds of patients for free. Um, Thanks to now, don't get me wrong, these guys are making plenty of money. Okay, all right, but they have really been good about giving us a therapy. Um, so and out of pocket costs are still $28,000. So it's a problem.
All right. I don't see any more questions, but we'll pause. We still have more time. So if you have any last minute questions, please put them into the Q&A box, chat box, use the raise hand feature. I always recommend that for big words. As you can tell, I will stumble over them. And then I'll just remind you that if you have questions, Dr. Styne is now one of our MAVEN Project volunteers doing consults. So please feel free to submit them to him on the community portal. And if you're interested in mentoring, especially around this area, we do have MAVEN Project volunteer mentors. Thank you.
And I would just say to the person who was talking uh about starting a program, in their clinic. If you have a local hepatologist you feel comfortable with, reach out to them. If not, reach out to us through the MAVEN Project. I think it's a great thing. Getting up sort of an organized system for getting these patients, especially if you're going to do compassionate drug through Gilead and AbbVie. And what I do is literally we flip back and forth between the two just to try to keep it fair, to Gilead and AbbVie. Though one is an 8-week drug and one is a 12-week drug. And I actually sometimes, like for example, if I'm treating a homeless person, I may go for the 8-week drug just because I think it's more likely that they're going to complete their medicine. And you can try to customize it a little bit for patients, but that's how we do it. And again, if that person who's starting a clinic wants any mentoring, as Kristen mentioned, we have consults and also mentoring where we can talk directly, one-on-one, real time.
Right. All right, I just see a couple of thank yous. There's a quick little reminder. I thought this was interesting in the chat. Remind Medicare patients to get cost estimate from lab before blood is drawn. They are required to be able to produce it. So just a little heads up for everybody. His contact information, you can reach out to Dr. Styne on our community portal. So I don't see any more questions. Thank you so much, Dr. Styne, for doing this today. Nice and early West Coast time. And thank you all for joining us this morning.
Everybody stay safe.